Good afternoon to all the listeners of EBC Radio Network. And of course, it's the time when we present the special show, brought to you by Robert Wood Johnson University Hospital. And today our guest is Dr. Eric Hargreaves. He's a PhD Director, Deep Brain Stimulation Clinical Research, neurophysiologist and DBS programmer at Rutgers Robert Wood Johnson Medical School. Deep Brain Stimulation we will be talking about, and number in the studio is 732-297-9886. The Deep Brain Stimulation team at Robert Wood Johnson University Hospital, Robert Wood Johnson University Hospital and Rutgers Robert Wood Johnson University Hospital have developed and continue to develop a comprehensive deep brain stimulation program supporting the patient throughout the duration of the treatment. And now, just at the time of the surgeries, RWJ is currently the only program with research funding specifically aimed at improving the accuracy of DBS surgery by actively participating in research. We seek to better understand the disease and how to improve the DBS therapy. And of course, joining us right now is Dr. Eric Hargreaves. And thank you so much to tell you more about this. So, Doctor, very pleasant. Good afternoon and welcome to EBC Radio Network. My first question to you is, what is deep brain stimulation, sir?
Well, that's the obvious question. And I'm actually very glad to be here and very glad to speak about this. Deep brain stimulation is almost what it sounds like. Essentially, we're stimulating deep parts of the brain. Now, of course, we're actually putting in very fine electrodes, very small places, and we're targeting parts of the basal ganglia, which is like part of the accessory motor system. And therefore, this often helps with motor movement for people who have certain neurodegenerative diseases, such as Parkinson's disease, essential tremor, and dystonia, which can be a genetic disease. And so essentially, during a surgery, we implant these stimulating leads, and then during a second surgery, a bit later, we implant a pacemaker device, and everything's all attached together and placed underneath the skin so nothing's visible and there's no ports or plugins. And essentially it runs by putting in a continuous train of electrical stimulation to those specific target centers, which then help disrupt the pathological firing of the basal ganglia that is being caused by those diseases such as Parkinson's. And that tends to normalize it and allow people to control things like their tremor or the bradykinesia or slowness of movement or even the rigidity, which often enables them to walk a lot better.
And Doctor, if you could please tell us, how does deep brain stimulation work?
Well, that's one of those things where there's a lot of research on it, but it's kind of a clinical accident upon finding it. The original treatments to help with Parkinson's tremor used to work by doing small lesions in these areas. And they used to target these lesions by doing some recording to listen to the brain structures as you go down, as well as ultimately to stimulate and to cause the symptoms themselves. So once they had some stimulating electrodes in the target sites that they wished to ablate or lesion, they would turn on the stimulation to cause the symptoms themselves. And then some brave neurosurgeon at one point turned one of the dials up to 11. And essentially, by generating a high frequency of stimulation as opposed to a low frequency which would generate the symptoms, it abolished the symptoms and made them go away. And at that point, there was a race on to figure out how to get a system like this implanted and permanently indwelling. And somewhere around 1997 in France, Dr. Benabid Aziz basically was able to successfully implant and have it approved by the FDA over here for essential tremor. And it just simply grew until about 2002, 2003, where it became FDA approved for the other movement disorders of Parkinson's and dystonia. And since that time, I think according to Medtronic, one of the big companies that manufactures the neurostimulators, we're close to about 150,000 people implanted worldwide.
I think that's really an amazing number. And Doctor, I just want to let our listeners know, if you just joined us, we're talking to Dr. Eric Hargreaves, and of course, He's a PhD, Director of Deep Brain Stimulation Clinical Research Program at Robert Wood Johnson University Hospital and Clinical Neurophysiologist and DBS Programmer at Robert Wood Johnson Medical School. And, of course, my next question to you, sir, is that can you tell me about what makes Robert Wood Johnson University Hospital's Deep Brain Stimulation team so unique?
Well, I think it's the fact that we actually have a team. I think when we first started this program some 5 years ago, I was surprised that this was that unique. It's just essentially getting a number of people who are experts together and getting them to talk to each other and meet and then set up a protocol and a procedure of how the whole process and therapy will be carried out. But since that time, I have learned that it's far more difficult than you would assume getting these people together, but we've managed to do it. And essentially, the core of our team, of course, is our neurosurgeon, Dr. RWJBarnabas. We could always refer to him as our team leader. Then we also have our two neurologists who are specialists in movement disorders and even DBS, Dr. Rocco DiPaolo and Dr. Daniel Schneider. And they're part of the neurology department here, which actually specializes in movement disorders, but only these two tend to work with the DBS group in particular. And they essentially do a lot of the diagnosis, the management up to the point where they may need the surgery, and then assess the individuals for their candidacy to see if they're appropriate for the surgery itself. And then they do a lot of the post-operative management itself, because, of course, once you have the surgery, you then need to tune up the device and adjust the medication, and it's going to be an ongoing process and takes a while. And then the rest of the team, or basically myself, who participates in the surgery and the post-operative management, as well as our nurse practitioner, Deborah Caputo, who also manages the medications afterwards, helps with the assessment, and helps me with a lot of the post-operative programming. But in addition to that, we also have a lot of outreach people. We have some physical therapists we deal with, because people who we have from the surgery, or even just in general with Parkinson's, often find a lot of benefit from getting physical therapy. We have some psychotherapists and psychiatrists on tap who are part of the team, Roseanne Dobkin and Matt Menza, who are pretty famous in their own right. Because often with some of the movement disorders, such as Parkinson's, there's comorbidities such as depression or great deals of anxiety that also need to be managed if you're going to work with the DBS. And so I'm surprised we managed to get all these people together and working well together and referring back and forth, and everything is nicely coordinated. But apparently that's what's unique about our program. There's very few programs in the New Jersey area, let alone programs that have such an extensive team working together.
And Doctor, my next question to you is, who is a good candidate for deep brain stimulation?
Well, of course, it tends to help with movement disorders, as I've mentioned. Parkinson's in particular, that's our largest volume next to essential tremor. But if it's Parkinson's, one of the things that we need to do is identify that it's a true idiopathic diagnosis of Parkinson's, because there's many other neurological degenerative diseases like multiple systems atrophy or PSP that can masquerade initially like Parkinson's. And so we need a good diagnosis, and that's why we have our specialized movement disorder neurologists and not just general neurologists out in the community. And often we work with general neurologists as well who refer to us for a specialized assessment to see if it truly is. So first thing is you really do need the good diagnosis of Parkinson's disease as opposed to having a number of Parkinsonisms, which means that you just have the symptoms, but not necessarily the same underlying cause. Beyond that, you essentially have to respond to some of the standard treatments that Parkinson does, carbidopa, levodopa, often known as Sinemet, made famous in the movie Awakenings. And this again goes back to the actual diagnosis itself. If your symptoms don't respond to the standard medication, which works well in the basal ganglia, then you probably will not work that well with DBS either. And then on top of that, you need to decide, what are your worst symptoms? What do you want most controlled? And what is it itself that DBS can control? Because DBS does have some difficulty working with some of the symptoms and ameliorating those, such as central issues like gait and balance in particular, and some of the cognitive deficits which may come on later. But things like tremor, which are often very debilitating, or the rigidity, which is hard for people to move and feeling very stiff and locked up, and some of the bradykinesia, the slowness of the movements. When they do move, it feels very slow. DBS is very good at controlling those and very good at maintaining control of those once it has it.
And Doctor, how long from the initial visit to the surgery?
Well, it's a screening process, and we want to go slowly, so we don't want to rush anyone, and I'm sure none of our individuals wish to be rushed. I think when we look at our data, it's going to be approximately 3 months. You have an initial visit, take the history, do the whole assessment, and then see if you have that diagnosis. And then once you pass that hurdle, then we need to have you receive an MRI just so we know that there's nothing else going on in the brain that we need to worry about when we're trying to do the surgery. Then we also do what we know as a dopamine challenge, where you would come in off all your Parkinson's medications, and we do one of the assessments. And then you take your medication, wait till it kicks in and is working, and then we do the assessment again, because we need to know that you do benefit from the carbidopa-levodopa. Otherwise, again, if you don't benefit from the medication, you probably won't benefit that much from the surgery. And so if you only gain a few points in our assessment, then it may not be worth undergoing the full surgery. So that's up to the time of the surgery. And then, of course, you would go through the surgery itself, and we stage it such that we have the stage 1, which is the longer part of the surgery, which we target and implant the stimulating leads. And actually, for a large part of that surgery, you may actually be awake as we record through the brain towards the targets. And then once we're there and put in the stimulating leads, one of the last things we need to do is see if we can actually gain some benefit or if there's any side effects from turning it on. So we basically turn on the stimulation while you're there on the operating table and start asking you a number of questions and seeing if things are better, things are a bit worse, or if we actually gain side effects if we go too high and if we need to shift the electrode or not. And then the second part of the surgery, which we do a week later after you've recovered, is actually implant the programmable device itself, or the neurostimulator, underneath the skin in the chest, and then hook up the whole system. And then about a week later, we actually turn on the DBS and start the programming, trying to fine-tune all their parameters of frequency, amplitude, pulse width, as well as begin to start taking down some of the medication. So a lot of this is also a adjunct therapy, meaning that we work with the medication. It's not a replacement for the medication. It works with the medications, but one of the best things about the surgery is that it often allows you to lower some of the medication that you've had to continually increase as your disease continues on, to the point where you may be developing side effects to the medications alone. So we're able to get you back below those thresholds so everything works well together and things are a lot smoother and you don't have those ups or downs or things that we often call motor fluctuations, where you go off too early or have to take too many of your meds.
And Doctor, how long does it take to work,
Well, we often can gain benefit right away once we activate the system, particularly for things like tremor. And what really slows us down a bit is working with taking off some of the medication, because you just don't want to go cold turkey on medication you've been taking for 5 or 6 years. You want to go a bit slowly. And since Parkinson's can be very complicated, and there can be multiple drugs, not just a carbidopa, levodopa, or vicinimet in place, there can be other things like dopamine agonists, MAO inhibitors, and a whole series of drugs. You want to take them down slowly and in combination. And, of course, as you lower the drugs, you actually turn up the DBS. So the whole process itself takes about 6 to 9 months, but you often receive immediate benefit from once we turn on the system, particularly in the evening or early in the morning when all your meds have gone out of the system since you haven't taken them at night, and you now have a foundation of DBS underneath that to assist with your movements and get going in the morning.
Once it works, how long does it take to last,
Well, once it works, and it doesn't stop working. But, of course, Parkinson's and other diseases are more complex than that. And so once it works and gains control of tremor and the bradykinesia and some of the rigidity, it will always capture those and always hold those at bay and will control them. But with Parkinson's, there are other symptoms that may come on later on in the disease that DBS may or may not be able to control. Things like hypophonia, meaning that your voice gets softer and softer and becomes more difficult to communicate. Things like balance and gait may come on later on. Some of the cognitive deficits that show up very much later towards the end. And again, since everyone's Parkinson's is slightly different, these things are not guaranteed to come on, but there are some things that DBS does not work well with. But what DBS does control, it will continue to control and control. We have some individuals who see us that we did not implant originally, but we've seen who have had DBS for over 10 years, and it still works well for them.
And Doctor, my last question to you is, what impact can deep brain stimulation have on someone's quality of life?
That's an easy one. A lot. We actually just received a nice email from a lady that we implanted just a month ago, and she just goes on how she's now able to exercise, and that her exercise ability is increased, and she's back to taking back her life from where she was almost immobile before. But in that regard, how the quality of life really works is when you're taking your medication every hour or even every 2 hours, and sometimes it doesn't work, sometimes it doesn't kick in, or sometimes it fails early, and you have what are known as motor fluctuations, meaning that you take so much of the meds and you get some of the side effects like the dyskinesias, the big writhing movements, and then all of a sudden the medication stops working even before you take your next dose. You're limited to what you can do, and you have small windows of opportunity to get out of the house, do shopping, or get out of the house and do some of your work, or get out of the house and just enjoy yourself. And so it's very much, when's my next set of pills? When's my next set of pills? Am I going to go off before that? Am I going to get caught in traffic if that happens? Am I going to be outside when that happens? And just your whole life is captured and scheduled to taking your medications, and that's just no way to live. What DBS is able to do is you're able to reduce the medications, and DBS, of course, it's on all the time. And so that smooths everything out. So even if you still need to take some medication to work with the DBS, the motor fluctuations are so minimal now, such that when you were on the medication alone and it stopped working, there was nothing to support you underneath, and you would bottom out and you would have your worst Parkinson's symptoms. In the same way, over time, you have to increase your medication so much that you would get the side effects. With the DBS, you're able to reduce the medication by so much that you no longer get the side effects because you don't have to take as much, and that when you do bottom out on the medication, you fall onto the foundation of the DBS, and everything then smooths out, and so people no longer, they often come to us after and say, oh, I forgot to take my meds, but it didn't matter because I have the DBS. Or often they come to us and tell us, I can no longer feel that my medication is kicked in. And honestly, whenever that happens, we go, yes, this is a very good thing. You can no longer tell that you're on medication or off medication because you're on all the time. And so everything's just smoothed, and they get days back. They no longer get little windows of time where they can do things. They get whole days, they get whole weeks, they get years back.
And Dr. Eric, I know it has been really amazing, and you have a program contact number that is 732-235-6678.
Yes,
and,
we do.
you could just also share the website if you want, and if anybody wants to get more details and information about all this.
Yes, I believe we have a website at Robert Wood Johnson. Just you could Google Robert Wood Johnson and DBS or Deep Brain Stimulation. You should find us there, and it should give you the same contact numbers. But that's the primary one that we use at the moment. Some of the other information is a little outdated, and we need to update it. But I received that specifically from our administrator, our contact person, Joan Glenn, and so that is the best way to contact us. To set up an appointment for an initial assessment would be 732-235-6678. And just because you come in for an appointment, again, it's the start of an assessment process where we try to work through you. And as indicated, not everyone is an appropriate candidate. And if you wind up not being an appropriate candidate, we try to direct you towards things that would help you with other neurologists or even at our own center. So just because you call up, it's not a guarantee that you're going to get the surgery, even if you want it or not.
I think this is really a great opportunity for our community, and anybody who needs help should connect with the Robert Wood Johnson University Hospital. And the number is 732-235-6678. And I'm talking to Dr. Eric Hargreaves, and he's a PhD, Director of Deep Brain Stimulation Clinical Research Program at Robert Wood Johnson University Hospital, and clinical neurophysiology, is a neurophysiologist and DBA programmer. And what a great honor to talk to you, sir. And I think health is such an important issue for all of us. And if you get the right help at the right time, you can live longer and you can enjoy a beautiful weather like today.
No, it is. It was actually very nice today. I was up in Newark working with some other people today. But no, we're actually really happy to talk about our program right now because after the 5 years, we've actually reached one of our first milestones of like over 100 cases. And that's actually really enjoyable for us when we did our celebration. It's basically more than double that was done by the program that was previously here before Dr. Donish took over in 2010. And right now, it's actually made us the fastest growing program in the Northeast, according to our company representatives. So we're actually getting a lot of attention from them because we're bringing in and doing some good work out there. So we're actually really happy to spread the word and have people come in and get the assessments if they think it will help them.
And I really want to congratulate all of you at Robert Wood Johnson University Hospital. I think on the behalf of our community, I think great work, Dr. Eric Hargreaves. Thank you so much for coming on live. We are really so proud to have you, sir.
No, I'm very glad to have spoken to you.
Thank you,
Thank
sir.
you very much.
Thank you.
Okay, bye.
Bye-bye. The special feature was brought to you with the kind compliments of Robert Wood Johnson University Hospital and Clinical Neurophysiologist and DBA program. And we spoke to Dr. Eric Hargreaves, and he is a PhD and he's a director. And thank you so much. I hope if any of you want to connect, 732-235-6678, or you can log on to www.rwj.edu/deep/brain/stimulation. And you can always call our studios or you can call our office to get the phone number. Have a wonderful